Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr. Sreenivas Concepts. This is Dr. Sreenivas, neurophysician from Rajahmundry, Andhra Pradesh, India. My email is 3klpm@gmail.com. I'm also the medical author of the two books Focused Neurology and Exam Oriented Clinical Neurology. We are continuing with a series of lectures of Prime Neurology. There are going to be about 50 episodes of Prime Neurology, and if one listens to all these 50 episodes of Prime Neurology, one would have acquired a good knowledge of neurology. Right now we are on part 37 Prime Neurology, CNS infections part 2 tuberculous meningitis. So in this episode we are going to discuss tuberculous meningitis. The usual causal agent Mycobacterium tuberculosis generally reaches the brain via the bloodstream, the bacteremia occurring intermittently with pulmonary tuberculosis. The meningitis may be a manifestation of miliary tuberculosis or may occur in association with one or more tuberculomatous foci in the brain, from which infection spreads to the meninges. CNS TB classification: it could be intracranial or it could be spinal. In intracranial we have tuberculous meningitis TBM with or without miliary tuberculosis, encephalopathy, vasculopathy, space occupying lesion which could be tuberculoma, single or multiple small plus miliary tuberculosis or tubercular abscess. Amongst the spinal forms we have POTS spine and POTS paraplegia, TB arachnoiditis, that is myeloradiculopathy, non-osseous spinal tuberculoma and spinal meningitis. Tuberculous meningitis. The pathologic reaction differs from that of other meningitis in that the meningeal exudate is concentrated at the base of the brain, its undersurface, and there are myriad of small tubercles, foci of caseation, epithelioid cells and Langerhans cells on the meninges and the external surface of the brain and ependyma. Hydrocephalus is usually present. Brain infarction is relatively frequent because of meningeal arthritis. Clinical and laboratory features: fever, headache, confusion and lethargy evolve less acutely than in other forms of bacterial meningitis, and cranial nerve palsies are more frequent. Occasionally the disease presents with some focal cerebral sign or seizure or with signs of increased intracranial pressure. Tuberculous meningitis presentation. The symptoms include headache, fever, vomiting, photophobia, anorexia. The signs include neck stiffness, confusion, coma, cranial nerve palsy, the third nerve palsy, sixth nerve palsy and seventh nerve palsy, but sixth nerve palsy is more common, hemiparesis, paraparesis and seizures. Spinal involvement: epidural compression of the thoracic cord from vertebral and disc destruction by caseating granulomas, tuberculous osteomyelitis, POTS disease, 1/4 of these cases, fusiform paravertebral abscess, Soyas abscess and gibbous, extradural cord tuberculomas causing more than 60% of cases of non-osseous paraplegia. Tuberculous radiculomyelitis may accompany. Tuberculous meningitis, the subacute paraparesis with radicular pain and bladder dysfunction. The complications include tuberculous arthritis and stroke, endocrine disturbances, hypothalamic disorder leading to a loss of control of BP and body temperature, diabetes insipidus, SAIADH, INO, hemichoria, spinal block and spinal arachnoiditis. How do we differentiate the tuberculous meningitis from bacterial meningitis? Age: it is seen in younger patients in tuberculous meningitis, whereas older in acute bacterial meningitis. The duration of illness is long in tuberculous meningitis and short in acute bacterial meningitis. Cranial nerve palsies occur early in tuberculous meningitis and late in acute bacterial meningitis. Strokes occur early in tuberculous meningitis and late in acute bacterial meningitis. Blood total leukocyte count is less than 10,000 in tuberculous meningitis and more than 10,000 in acute bacterial meningitis. Hyponatremia is frequent in tuberculous meningitis and rare in acute bacterial meningitis. The CSF total leukocyte count is less than 750 per 1000, 750 to 1,000 in tuberculous meningitis, but more than 1,000 in acute bacterial meningitis. The predominant cell is lymphocyte in tuberculous meningitis, but neutrophil in acute bacterial meningitis. The CSF glucose is less than half in tuberculous meningitis, but low or absent in acute bacterial meningitis. Tuberculosis, the CSF diagnosis. The CSF formula is diagnostic. Increased pressure, pleocytosis, 100 to 500 cells per cubic millimeter, with lymphocytes predominating after a few days. The protein content increased to 100 to 200 milligrams per deciliter or more, and low glucose, less than 40 milligrams per deciliter. Cultures do not become positive for 3 to 4 weeks or longer. These problems are being overcome by the use of the polymerase chain reaction, a method of DNA amplification to detect small amounts of tubercle bacilli. Tuberculosis, the neuroimaging. Chest films may demonstrate the presence of healed or active pulmonary lesions, and CT and MRI may reveal hydrocephalus, tuberculoma, gadolinium enhancement of the basal meninges, or zones of infarction. So here you can see the hydrocephalus. The neuroimaging features of tuberculous meningitis: hydrocephalus, basal meningeal enhancement, tuberculoma, infarct, pre-contrast basal hyperdensity, but there can be normal MRI also. Advances in neuroimaging: the CE MRI with FLAR, best for CNS tuberculosis, to differentiate pyogenic abscess from tuberculous abscess. Magnetic transfer MR imaging or MR spectroscopy, the prominent lipid peak. We check out on high lactate and no amino acid preference. Professor G.K. Ahuja criteria for tuberculous meningitis. We have clinical criteria, cerebrospinal fluid criteria, radiological criteria. The clinical criteria includes fever and headache lasting more than 14 days, that is mandatory. Vomiting, alteration of sensorium or focal deficit is optional. The cerebrospinal fluid, pleocytes with more than 20 cells, predominantly greater than 60% lymphocytes, protein greater than 100 milligrams, sugar less than 60% of corresponding blood sugars, negative Indian ink studies, and cytology for malignant cells in relevant situations. Radiological, CT studies on the head showing 2 or more of the following: exudates in the basal cisterns or in sylvian fissures, hydrocephalus, infarcts, or gyral enhancement. The treatment of tuberculosis. Treatment: if unrecognized and untreated, tuberculous meningitis is invariably fatal. Treatment consists of administration of a combination of drugs: isoniazid, 5 mg per kg daily for adults and 10 mg per kg for children; rifampicin, 600 mg daily for adults and 15 mg per kg for children; ethambutol, 15 to 25 mg per kg per day; pyrazinamide, 20 to 35 mg per kg per day. The drugs need to be given for 10 to 24 months as a rule. Ventricular shunting may be needed for patients who remain stuporous with large ventricles. The multi-drug resistant treatment includes: never add a single drug to a failing regimen; use at least 3 previously unused drugs, one of which should be a fluoroquinoline. Other drugs include amikacin or kanamycin, ethionamide, and cycloserine. Duration of treatment should be at least 18 months, that is 1.5 years. So these are the wonderful concepts of tuberculous meningitis. The other interesting concepts of clinical neurology, I put it in a book called Exam Oriented Clinical Neurology, written by me, Dr.Sreenivas, published by White Army. This book will be very useful for students appearing for clinical neurology exams, and if interested, this book could be purchased. The other book I wrote is Focused Neurology, written by me, Dr. Sreenivas, published by CBS Publishers and Distributors. This book contains all essential elements of theoretical neurology and will be very useful for students appearing for Viva OC or orals. This book is available online from all leading booksellers including Amazon. So if interested, this book could be purchased online. As I said earlier, there are going to be 50 episodes of Prime Neurology, and if one listens to all these 50 episodes of Prime Neurology, one would have acquired a good knowledge of neurology. We are just done with another episode of Prime Neurology. If you have enjoyed these wonderful concepts of tuberculous meningitis, please like and subscribe to my YouTube channel, Dr. Sreenivas Medical Concepts, which is India's leading neurology educational YouTube channel, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.